Frailty is a part of normal aging.
It's the lack of resilience, the lack of ability to bounce back.
Dr. Amanika Kumar says frailty also may be coupled with muscle loss, which is called sarcopenia.
Both frailty and sarcopenia seem to be age-related. So as we get older, we have a higher risk of both of those things. They also seem to be cancer-related. So if you have a solid tumor, you seem to be at risk of both of those things.
So how can you prevent both frailty and sarcopenia? Dr. Kumar says the best medicine is to keep moving.
If you have a loss of muscle, can we gain muscle? There's a lot of research being done by some therapeutics and pharmaceuticals, but what does seem to actually help are things like exercise, including weight-bearing exercise.
You don't have to run a marathon or power lift. Just stay active. Walk 30 minutes a day or get out in the garden. Do activities you enjoy.
I do think that can make a difference in your overall feeling of well-being and your overall fitness.
For the Mayo Clinic News Network, I'm Jason Howland.
Hi, everyone. My name is Dr. Ria Fyffe-Freil. I'm a first-year clinical chemistry fellow in the Department of Laboratory Medicine and Pathology here at Mayo. And my PhD is in molecular physiology, where I studied liver transplants. So transitioning over to clinical fellowship was a natural progression for me. As an orthopedic patient myself, with a genetic disease that wreaks havoc on my joints, I know a few things about falling down, balance, arthritis, and naturally, when I met my co-presenter, when she came to meet my cats to take care of them when we were going away on vacation, we hit it off immediately, and you'll understand why very shortly. So now I'll introduce my friend and colleague, Grace Chaney, who will pick up this talk when I'm finished and carry you through to the end. So Grace received her BS in kinesiology with a focus in biomechanics from Miami University in Oxford, Ohio. She obtained a certification through the American College of Sports Medicine and Personal Training and earned the Exercise in Medicine credential. She then came to Mayo, where she is in her first year of the GREP program performing orthopedic surgery research concerning shoulder and elbow injuries. She's applying to medical school and has her sights set on orthopedic surgery as a specialty. So her passion for human physiology, anatomy, and orthopedic rehabilitation research was developed through personal experience as a competitive soccer player who got injured and required surgeries and months of physical therapy to recover. So I will start the presentation introducing the topic of how our bodies change as we age in terms of bones and arthritis. And then Grace will take you into what you can do about it to keep yourself as mobile and injury-free as possible in your golden years. She will even explain some balance tests you can do at home to challenge yourself. So before we dive in, we want to thank everyone that made this talk possible, the Mayo Fellows Association, the Charterhouse residents and staff for inviting us back this year to talk, Nicole Gerton, who is the Mayo Clinic's Injury Prevention Coordinator, and Grace's research mentor, Dr. Sean O'Driscoll. So today we're going to talk about how our muscle and skeletal systems change with age, and not just with old age. Changes start the day we're born. So babies tend to have a lower muscle tone and open growth plates to accommodate all of the growing that they do as they turn into adolescence. And when puberty hits, that muscle mass starts to increase and their bones strengthen. Participating in sports and other physical activities as teenagers helps with this. When we get into adulthood, we reach a plateau, and things ride steady here for a while, maybe several decades, as long as we stay relatively active. And then when we hit our 60s, despite our best efforts sometimes, we begin to lose some of this muscle mass that we work so hard for, and this is called sarcopenia. Our joints begin to deteriorate and the mineral content in our bones can decline. And combined, these three insults can lead to a world of problems if not taken seriously. So today, Grace and I will introduce these three main changes experienced by our musculoskeletal system as we age. And then Grace will show you some easy exercises that you can do at home to keep yourself strong, healthy, and most importantly, mobile as you move farther away from your shoe size in age and closer to the number of sweets that I ate over the holidays. Okay, so our skeletal muscles. So here we have our skeleton man, skeleton over here, muscles over here. And our skeletal muscles change structurally and functionally as we age. And the culmination of these changes is called sarcopenia. And as our muscle mass decreases, which is reflected both in the density of the myofibrils, so our little muscle bundles of muscle fibers that we have here, and in the total number of fibers, so the density of the fiber and the number of fibers. This culminates in a reduced strength and physical performance and can lead to frailty syndromes and falls, which leads to, in extreme cases, immobility and functional dependence. And so in the research community, the causes of sarcopenia are still hotly debated, but it's become apparent that the involvement of both the muscle itself and the nerves that innervate those muscles and send them signals to contract play a role. So voluntary movement of our muscles is a highly specialized and very orchestrated function of the body that requires efficient communication between the nervous system and the muscles. And so the decision to move triggers an excitation of the upper motor neurons that live in the motor cortex in the brain. And these cells transmit an action potential way down to the lower motor neurons within the posterior area of the spinal cord. And that electrical impulse is then spread from the lower motor neuron to the cell body of the muscle fiber at the neuromuscular junction. And this is that specialized synapse between the muscle and the motor neuron. And the incoming action potentials from the neurons tell the muscles when to contract. And the exact causes of the kind of malfunction in communication between the neurons and the muscles is not well understood. But we do know that as folks age, the healthy mitochondria that once thrived and produced a ton of energy that our muscles need to contract when we were younger are no longer as healthy nor as numerous in our elderly muscle. And mitochondria, remember, these are the powerhouse of the cell. They make a ton of ATP, but they can also be damaged by the accumulation of reactive oxygen species, which we all accumulate over time. And so this could be one reason that mitochondria end up damaged as we age. And so still don't really know the cause of sarcopenia, but we do know that it's a complex process that involves lots of different players at different levels of the body, from brain all the way down to the target muscle that moves the part of the skeletal system that you'd like to move. So in terms of numbers, the muscle mass decreases approximately 3 to 8% per decade after the age of 30, which is a little terrifying for me. And the rate of decline is even higher after the age of 30. Or sorry, after the age of 60, not 30. So here we want to show you a study of the actual muscle mass, or the area of muscle, and how that relates to the strength or muscle torque. So the amount of muscle in the upper leg is represented by quadricep muscle area, or QMA, and the strength of the muscle is represented by muscle torque, or MT. And these researchers in this study followed a cohort of nearly 1,700 men and women between the ages of 70 to 79 for a 5-year period, which is a really long time for a cohort study. And they found that there was a significant decrease in leg muscle mass in both men and women who were either at a stable weight in these gray bars or losing weight. And this corresponded with a significant decrease in muscle strength or muscle torque. What was interesting in this study is those men and women who were gaining weight, these black bars, also saw, despite the fact that they had an increase in muscle mass in their legs, they also saw a decrease in muscle torque or muscle strength. And so this shows that not all muscle after a certain period in life is capable of being as strong and healthy as it once was, likely for the reasons that were discussed on the previous slide. So we've talked about the impact of muscle, but what happens to joints as we age? So as we age, joints, the movement of these joints becomes stiffer, less flexible, because the amount of fluid in this joint cavity decreases in amount. And the cartilage here that covers the ends of our long bones thins. And our ligaments and tendons that help hold our joints together and make them strong and prevents them from sliding in directions that they're not supposed to, they shorten and become less flexible. And all of this contributes to making those joints feel very stiff. And so joint range of motion tends to decrease as our age increases. And so as a result of this, both our passive and active range of motion decreases. And so in a healthy joint, the cartilage provides cushioning for smooth and easy movement in that joint. So the synovium, the synovial membrane that lines that joint cavity, produces synovial fluid. It fills that joint cavity, lubricates everything, cushions, and keeps that cartilage healthy. But as the muscles decrease in size, the joints have to make up for that by absorbing more of that impact, leading to wear and tear of the cartilage and encouraging the erosion of the cartilage over time. And so as the amount of cushioning that's available in the joint decreases, movement becomes stiff, uncomfortable, and even painful. And this discomfort can lead to a reduction in physical activity because it's uncomfortable to move. And this further promotes joint deterioration. So it turns into a downhill cyclical snowball effect once inflammation and pain starts as your joints begin to deteriorate. So osteoarthritis is the term that we use to describe painful inflammation in the joints. And it is the most common form of arthritis among older folks and the most frequent cause of physical disability in this population. So as I mentioned, osteoarthritis is when cartilage, the tissue that covers and cushions the ends of those bones within the joints, breaks down and wears away. So this leaves those bones susceptible to rubbing against each other with no cushioning, and this results in stiffness, pain, and swelling in those joints. So the joints that are most affected by osteoarthritis are the hands, the lower back, the neck, and all of your weight-bearing joints like the knees, the hips, and the feet. And we actually have a really awesome database here in Rochester called the Rochester Epidemiology Project, which was started back in 1966 through an NIH grant that was headed by Dr. Leonard Kirkland, and his efforts linked all medical providers in Olmsted County, Minnesota, which allowed them to collaborate and link their medical records. And so in 2016, the Rochester Epidemiology Project celebrated their 50th anniversary. And only a year later, all of that de-identified medical data was made available to the public through an online database. And And so it allows us to pull information about all kinds of conditions in our area. And you can see here on this map that Southeast Minnesota and kind of this northwestern part of Wisconsin are the areas that this study encompasses. So we pulled data specific to this area. You can see here we're in Olmsted County. And in our area, osteoarthritis is quite prevalent. Between 8 to 16 people per 100 affected in our community by osteoarthritis. So one of the unfortunate consequences of osteoarthritis is its negative effect on walking and mobility. So a 2016 study looked at the gait speed, or the speed of walking, in men and women of different ages. So the rate of change in gait speed were estimated using data from baseline, 3, 6, 9, and 14-year follow-up. Again, really long time to follow these patients. So it gets really good data showing us how walking changed over time. And so the message conveyed by these results is really, really clear. Decline in mobility with age is evident and accelerates quickly near the age of 65 to 70. And these findings suggest that an early decline in mobility is detectable and may guide strategies to prevent targeted or may guide strategies to allow us to target certain populations and individuals from this decline in mobility due to osteoarthritis. So here in men, you see where this decline starts around 65 and just falls off precipitously. In females, you see the gait doesn't fall off quite as sharply in women and seems to plateau around 75. And it's interesting that gait tends to fare worse in men compared to women. And I'll show you on the next slide why that's interesting. So we've covered arthritis, where bones are exposed due to cartilage breakdown and painful inflammation ensues. But what about the mineral content in bones and their density? Age-related bone loss involves a gradual and progressive decline, and various studies have confirmed that peak bone mass is achieved in individuals between the ages of 25 and 30. After this point in time, bone mineral density declines in both men and women, but at different rates. So I'm not sure about Grace, but I've certainly passed my prime in bone density. So note in this figure on the right that there is a rapid bone loss phase in women beginning near the onset of menopause and continuing through the entirety of menopause. And you don't see this rapid decline in men like you do in women. With the exception of this period of rapid bone loss, the slopes of these two lines are relatively similar. And this phase of rapid loss is associated with an estrogen deficiency because estrogen plays a really important role in calcium metabolism and osteogenesis, or the formation of new bone. So how do we measure bone density when an old-fashioned X-ray just won't do the trick? So we have technology called a dual energy X-ray absorptiometry scanning, excuse my mouthful of words, or DXA for short. So DXA is a method of measuring bone mineral density at the spine and hip. And this technology plays a really important role in predicting an individual's risk of both osteoporosis and frailty fracture, or fragility fracture, which I'll explain a little bit more in a minute. And so this provides clinicians the ability to monitor bone density or bone mineral density over time, and how the body's responding if treatment is implemented. So this is what one of those scanners looks like. And over here, so you just lay on the table, and it's similar to an X-ray, kind of combined with a CT, but you're not quite as enclosed. So, or an MRI, if you've been through an MRI, but not quite as enclosed, which is great for those of us with claustrophobia. So you can see over here on the right, this is kind of showing you where your bone density should be if it's normal. Osteopenia is what we call kind of a precursor to osteoporosis. We can equate that to pre-diabetes before diabetes. So when your bone density gets into this yellow range, you're pre-osteoporotic, so to speak. And down here you have age. So this is where we expect folks to land based on their age. And so we expect as we move into the future that more and more primary care providers will be ordering these scans because they're really good at predicting somebody's risk for osteoporosis and fractures in the future. And for reasons that we'll talk about in a minute, it's really important to prevent these fractures before they happen because they're associated with really intense morbidity and mortality the older the population. And so not surprisingly, the prevalence of osteoporosis, for the reasons we discussed a few slides ago, is higher in women than in men, about 3 to 4 times higher in our area, which is on par with the national average. According to the CDC, women are 4 times more likely to have osteoporosis than men. And so again, in our area, women have a sharp peak in the development of osteoporosis in the 40 to 64 age group is where it starts to peak, while the increase in prevalence over time doesn't occur until about a decade later in life than men, nor does it peak as sharply. And here you can see that 3 to 4 times more likely ratio that the CDC describes. Okay, so we're going to talk about how osteoporosis can impact your risk for fractures. So a fracture arises when the load-bearing capacity of a bone is exceeded by the forces applied to it. For example, during trauma. This capacity is influenced by bone mineral density, but also by bone geometry, microstructure, and quality. So as you can see in this image, an osteoporotic bone has a much less dense interior than a healthy bone. So it's no surprise that it can't withstand as much external force as a healthy bone. It has less mineral content, it has larger air pockets, and it can't withstand as much force. So when it breaks, this is called a fragility fracture. And this type of fracture can be caused by very, very low energy trauma. It wouldn't cause a fracture in a healthy bone. And so the incidence of fragility fractures is highest among elderly women, with 1 in every 2 women suffering an osteoporosis-related fracture in their lifetime. That's 50%. In adults over age 65, men are more likely to die following a hip fracture than women. And hip fracture patients are around 3 times more likely to die than the general population from any cause of death. So following a hip fracture, patients have 10% mortality at around 1 month and 30% mortality at 1 year post-fracture. And the reason that I bring this up is because I used to work in EMS, and I would respond to people's houses when they fell and take them to the hospital. And it is always really scary when someone over the age of about 65 falls and breaks a hip, because just anecdotally, we know that outcomes tend to not be very great, and there is data to back that up. And so reducing our risk of not only falling, but osteoporosis and fragility fractures greatly reduces your mortality associated with age-related mobility challenges. And so now I am going to turn things over to my colleague, Grace.
I think it's safe to assume that we have all taken a tumble at some point in our lives. I know I have. But as we grow older, the risks associated with falling become greater. As my co-presenter explained, we lose muscle mass and bone density as we age. Our sense of balance deteriorates, and we take longer to recover from injuries, especially falls that result in fragility fracture. The fact of the matter is, our balance begins to decline somewhere between the ages of 40 to 50. The good news, however, is that it is possible to slow our loss of balance, improve our strength, and reduce our risk of future falls by participating in regular exercise. The recommended guidelines for physical activity from the American College of Sports Medicine state that we should participate in what is known as multi-component exercise. Essentially, what multi-component exercise is the incorporation of aerobic training, resistance training, flexibility training, and balance training into one exercise routine. By completing all these different components of exercise, we can obtain the greatest health benefits. Tonight, for the purposes of this presentation, we are going to be focusing on balance training, what it is, why it is important, and how you can incorporate it into your life. Balance is a term used to describe the ability to maintain an upright position. You may have also heard the term postural stability. Postural stability describes balance in a more specific manner as the ability of an individual to maintain their center of gravity within a base of support. There are two main types of balance, static and dynamic. Static balance is defined as balancing in one place without any movement, whereas dynamic balance is defined as balancing with movement. This could be such as walking or dancing or reaching forward to grab an item off a counter. Both static and dynamic balance have been found to decrease as age increases. Decreased balance is attributable to an age-related decline in multiple physiological systems that contribute to decreased flexibility, decreased muscle strength, a slowed gait speed, increased reaction time, and decreased movement confidence. In addition to an increased risk of falls and fragility fracture, diminished balance and mobility may also limit activities of daily living and participation in leisure time activities. Accordingly, it is essential that balance exercises be incorporated into the physical activity programs of older adults in order to prevent injury, improve posture, improve muscle strength, increase self-efficacy regarding balance control, and finally, to increase or maintain our gait speed. As a result, older adults will be able to maintain their quality of life and autonomy as they age. In order to improve our balance, we must first evaluate it. There are several types of balance assessments that can be done in order to get baseline information. The timed up and go test, or Tug Test for short, is a very commonly used assessment in clinical practice as it evaluates both static and dynamic balance. The assessment is fairly quick, requires little equipment other than a chair and a timer, and can even be done at home. We had hoped to be in person with you all to help demonstrate the Tug Test, but since we cannot be in person with you guys, we wanted to incorporate a video of the Tug Test just to give you a better idea of how it is run and performed.
The timed up and go, or tug, tests functional mobility. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move. And stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
So now that we've evaluated your baseline balance, it's time to start incorporating balance exercises into your routine. Again, I apologize that we could not be there in person with you all to share these exercises and answer questions, but I hope this video provides you with some more information and some ideas of exercises that you can incorporate into your routine.
The underlying myth that falls are an inevitable part of getting old. The surprising truth is our risk of a fall decreases with this one simple thing. See, starting at 30, our muscles can lose up to 8% of their strength every decade. So, by the time we're 80, we potentially lost 40% of our strength. We can help reverse this trend, though, with 6 simple exercises widely used by physiotherapists to keep us mobile and independent as we age. All you need is a steady support, sensible shoes, and a little time each day. Exercise 1, heel raises. Stand tall and hold your support. Then lift your heels off the floor, taking your weight through the front part of your feet. Hold this position for 3 seconds. Then slowly lower your heels to the floor. Repeat this 10 times. Exercise 2, toe raises. Stand tall and hold your support again. This time, raise your toes, taking your weight in your heels. Keep upright and don't stick your bottom out. Hold this position for 3 seconds, then slowly lower your toes. Repeat this 10 times. Exercise 3, heel toe stand. Stand tall sideways on your support, with one hand on your support. Now put one foot directly in front of the other to make a straight line as shown. While looking ahead, take your hand off the support if you can and balance for 10 seconds. Take your front foot back to hip width apart and place the other foot in front instead. Balance again for 10 seconds. Exercise 4, one leg stand. Stand close to your support and hold it with one hand. Balance on one leg, keeping the support knee soft and your posture upright. Hold this position for 10 seconds, then repeat on the other leg. Exercise 5, heel toe walking. We'll be walking forwards for this one, so use a support like a sideboard. Stand tall with one hand on your support. While looking ahead, place one foot directly in front of the other, so your feet form a straight line. Then move the back foot in front of the other. Continue a steady walking action for 10 steps. Then, take the feet back to hip width apart. Turn around and repeat the steps in the other direction. Exercise 6, sit to stand. Grab a sturdy chair and sit tall towards the front with your feet tucked slightly back. Now lean forward slightly and stand up. If you need to, place your hands on the chair for extra support. Carefully step back until your legs touch the chair. Then slowly lower yourself back into the chair. Repeat this 10 times. That's it. Keep these up and you'll help your muscles stay strong.
So if you're anything like me, you like simplicity and to make incorporating exercise into your life as easy as possible. And you also want to make sure that you spend your time doing activities that will actually generate tangible results. Well, a 2016 study looked at the efficacy of a self-administered balance-enhancing exercise program termed FyffeFreil. The program was thoughtfully designed using just 7 exercises, which included squats, calf raises, one-legged stands, head rotations, and rotational hops. Exercises were completed on 2 types of surfaces, a hard solid floor and a soft exercise mat. There were 40 participants in the study, ranging from ages of 60 to 80 years old, and they performed 6 weeks of FyffeFreil training at home on their own for an average of 16 minutes 4 times a week. Participants completed the Tug Test at baseline and then again at the end of the 6 weeks. Can you guess what the results were? There was an overwhelmingly positive response from the home balance program. For instance, one-legged standing time improved on average 32% across participants, and the timed up and go tests scores also significantly improved. It is also important to mention that participants completed what's known as a balance confidence assessment. This type of assessment looks at how confident people feel in performing exercises where balance is altered. The scores for this assessment also significantly improved by the end of the program, meaning that people were more confident and comfortable performing exercises and activities where their balance was compromised. Overall, what this study found is that a simple home-based balance program was both a time and cost-effective way to improve balance and balance confidence in older adults. I think we all have 16 minutes a few times a week to work on our balance in order to prevent falls and potential fragility fracture. Besides the balance exercises we shared with you tonight in the video, another great local resource for balance training is brought to you by the Southeastern Minnesota Area Agency on Aging. They have partnered with WellConnect and Juniper to provide free in-person and virtual exercise classes that focus on proprioceptive and balance training here in Rochester. These programs are evidence-based and are designed to reduce fear of falling and increase the activity levels of older adults. You can find more information regarding these classes and sign up for them by visiting yourjuniper.org. So in conclusion, falls are serious at any age, yet fractures are more likely as a person ages. Safety measures to prevent falls, along with educating older adults to remain alert, work on balance, and partake in exercise for optimal bone density and muscle strength, are essential for minimizing the ramifications of falls and fragility fracture. Inevitably, aging changes our physiological abilities, yet lifestyle management can help prevent and minimize the risk of injury and improve quality of life and autonomy.
We want to thank you for having us to talk to you about mobility, issues that pop up in the musculoskeletal system as we age, and Grace for her expertise in exercises you can do. She's actually a really fantastic resource, and I wanted to provide you my email. If you have any questions, feel free to email me and I will pass them along to Grace if they're within her area of expertise, and we will get back to you. And hopefully next year we can do this in person. Stay safe and stay mobile.